محمد Dr. Basim can start now ولا لسه؟
You can start, Dr. Basim.
Thank you. Good evening. My name is Basim Fliga. I'm the president of the Egyptian Shoulder Society. And I am very glad and honored to announce the first webinar of our society in collaboration with the South African Shoulder and Elbow Society. It is the beginning of an African and international interaction of experience in the field of shoulder surgery. And it is the milestone of the foundation of the African Shoulder and Elbow Society. Special thanks to the great efforts of Leon, the president of the South African Shoulder and Elbow Society, for his great effort to make this event happen. Also, thanks to all the participants, Doctors Muhammad Ut, Ajmal Ikram, Anthony Rocher, Yasser Safuri, Ayman Mansour, and the moderator, Dr. Rami Al-Naqib, whom I am honored to give him the moderation to start this webinar. Thank you very much. Dr. Ayman. Dr. Rami.
Thank you, Professor Basim. Thank you. Welcome all participants to this very nice webinar. I think we will have about 6 talks. Then at the end of the talks, there will be half an hour for discussion. There is a tag with question and answers, Q&A. If you have any question, you can type your question and we'll answer it in the at the end of the meeting. Without undue delay, we will start with Professor Ayman Mansour, who will talk about conservative treatment in Erbs palsy. Professor Ayman.
Thank you, Rami. I'd like to take the chance to congratulate all of us for the Eid al-Fitr. كل سنة وحضراتكم طيبين. As we all know, that Erbs palsy is a form of obstatic brachial plexus palsy. The injury might be just a stretch, and sometimes it extends to the avulsion of the root. The brachial plexus is the group of nerves that connects the spinal cord to the muscles and it allow for the movement and for the sensation of the upper limb all. If we have a more anatomical look at the brachial plexus, we'll see that C5 and 6 will share in most of the muscle that control the shoulder movement, the long thoracic nerve, and here they are sharing the posterior cord to end with the axillary nerve for the deltoid, also the suprascapular nerve for the rotators of the shoulder. In Erbs palsy, in the early days, we can see by clinical assessment that it's all directed to detect other problems, like if you have an associated fracture, if you have something with other injuries due to a birth problem. The posture is a classic for the policeman tip deformity, as they all said, with an adducted shoulder, then internally rotated, we can see in the photo. We used to in these early days, I don't think that scoring gives an idea about the prognosis, but we have different score system that can we score the arm movement by it. The NARACAS classification stratified the prognosis based on the root extent of the root involvement. It takes how many roots involvement and the site of the weakness to give you what is likely the outcome. To cut it short, if we have type 1 with a 5-6 palsy, he assumed that it's about 80% of these patients will have a spontaneous recovery. If you have a C7 also in our injured part, what's called an extended Erbs palsy, then we have a 60% only that will go into full spontaneous recovery. In type 3, we have a total plexus. It's a completely flail, and I think this part will end in surgery. And you have also a Horner syndrome with your problem. That means that we have those apparentoses and the eye changes. Then this will make it very hard to go with a conservative treatment, and this chilled type, this part of the injuries will go into surgery. As we said before in the clinical examination, that investigation in the early days is directed to detect other problem than the nerve problem. We do chest X-ray for the diaphragmatic affection. In the diaphragmatic paralysis, I mean association with phrenic nerve injury, and this may add to your decision to push the patient towards the surgery as early as it's expected. If we have an X-ray for the humerus and it's fractured, we'll do the proper management. By 3 months, we can start to do nerve conduction study and to detect the site of injury, and also to try to take the prognosis. If you have no shoulder recovery by 6 months, then it's time to redo your electrophysiological studies to be sure whether to continue in your plan or to switch to surgery. MRI myelogram, it's gain popularity in a way to predict what the exploration will result on, but sometimes very hard to do, and it requires anesthesia for the neonate also. Whether to do a surgery or to continue conservative, actually there is no clear guidelines in the process. If you read in the literature, there's also always suggestions, but if you have no spontaneous recovery for the first 3 months, sometimes you can push it to 6 months of birth. After birth, then you have a clear demarcation to start to prepare for your surgery. This is as if you delay the surgery for a long time and then it's been clear that it's time for surgery, you will lose a lot of time and you will lose a lot of muscle recovery. It was agreed upon that the biceps recovery at the 3 month will be the cut to have a complete or a near complete shoulder recovery. If you have 3 months without biceps recovery, then you should shift the patient to surgery. If you have a recovering biceps, then you can postpone to 6 or 9 months later to have a good chance of recovering shoulder function, and any deficit can be managed by tendon transfer or osteotomies later on. Other associated nerve injuries as the diaphragmatic paralysis or Horner syndrome will be in favor of pushing the patient towards surgery. The problem with continued conservative treatment is that sometimes the global shoulder function will become worsened by the imbalance in the muscle. The child, also the growth of this limb will be a little less than the contralateral side. With incomplete neurologic recovery, we'll have a favor of the internal rotators muscle will be overpowered with a weaker external rotator or abduction, shoulder abduction muscles. And this will change both the osseous structure of the shoulder and the function of the shoulder. You will have an internal rotation contracture, an ability to extend the shoulder, to external rotate the shoulder. With growth, there will be glenohumeral dysplasia in 60 or 80% in the form of retroversion of the glenoid, flattening of the humeral head, and posterior subluxation. If this subluxation or the displacement is more than 50%, then a pseudoglenoid will start to develop. Contracture development is one of the serious problems of continued in conservative treatment, as there will be an abduction contracture that will make the scapula in less natural position and will trouble the muscle controlling the scapula, later leading to shoulder pain later on. Actually, it favors for the global shoulder function because positioning the glenohumeral joint in abduction will add to the abduction range of the whole shoulder. Patients with glenohumeral dysplasia will have also an internal rotation contracture. On this should be take care during your releases or if you are planning for a later osteotomy. The conservative treatment will start even for 3 or 4 weeks after birth. Smooth movements, sensory stimulation, stretches, vibration, brushing. We have to not to push towards electrical stimulation. It's a complementary mean of exercise. Sensory stimulation is important also, and the sensory input is very important for the global function of the arm. As we can see, they are all simple exercises that can be done by the mother or the father on a home base. And if you continue on a conservative treatment for an older child, 9 months or something, you can start doing it periodically at a physiotherapy center. During the first 6 months, we're trying to prevent the fixed deformities by maintenance of the range of motion in the form of activities and exercise to promote the movement, to try to prevent stiffness. As we said before, sensory stimulation is very important to promote the arm awareness. Sometimes splinting, night splinting especially, help in preventing contracture by stretching of the overpowered muscles. And electric stimulation is complementary, as I said. The most important tool in fighting the brachial plexus deformities in children is parent education. You have to educate the parent for what's right and what's wrong. I think this is a very small talk about the function of the conservative treatment in such injuries. And we'll have another aspects of the management later on in the form of microsurgery or tendon transfer or osteotomy. Thank you, Dr. Rami. Thank you, everyone.
Would you allow me to share my screen?
Yes. Now, Professor Yasser will talk about microsurgery in Erbs palsy. Please, Professor Yasser, share your screen.
Good evening, everyone. I will be talking about, in this presentation, about the outcome of microsurgery reconstruction and nerve graft in upper brachial plexus injuries, C5-6, at an early stage, which is 3 to 6 months. I will show the indications, the surgical procedure, and the outcome. So as Dr. Ayman said, obstetric brachial plexus is traction, injury of the brachial plexus during difficult labor, which may injure the upper part of the brachial plexus and ends by paralysis of the shoulder and elbow muscles, or slight improvement, but there's a deficit in function later on during his life. We want to detect these patients and early interfere by surgery and microsurgery reconstruction. So I agree with Dr. Ayman. Darkas classification gives us an idea about the injury of the lesion. Is it an upper brachial plexus or extended upper? My talk will be on the C5-6 and extended C5-6-7 injuries. Most of these cases recover, 80–90% recover. Others do not recover at all and end by contractions and deformities, or there is partial recovery, but there's a functional deficit. So there are indications for surgery. As Dr. Ayman said, at an early stage, 3 to 6 months, we examine the patient properly. If there is no biceps, or if it's a global type, or if it's a Horner syndrome with avulsion and a hand problem. These are the main or the general indications for microsurgery repair or reconstruction as early as 3 months. As you see here, this is the clinical picture of the patient who will need microsurgery. He has this policeman tip deformity. Is unable to flex the elbow and also the shoulder, as Dr. Ayman. So your eyes is always on the elbow and the shoulder. If this is the case, then this patient will need microsurgery reconstruction. What are the types of surgeries? It may be repair, or it may be in the nerve, as nerve grafts, neurotization, neurolysis. But in our experience, we had no cases for direct microsurgical repair, and we had no cases with neurolysis only. But all these cases required microsurgery reconstruction by nerve grafts, and some cases, about 11%, required in addition neurotization in the form of transfer of the spinal accessory to the suprascapular nerve. The anatomy is complex, either the gross anatomy or the internal anatomy of the nerve. The approach is needs experience. You always identify the subclavian artery, the phrenic nerve, and the localized lesion of the nerve, proximally and distally. The nerve topography is also important. The surgeon should understand the nerve topography for good reconstruction of the nerve. As you see here, the approach, we begin with a transverse incision parallel to the clavicle, then they go back with the posterior triangle of the neck. We identify the lesion proximally and distally. Then we reconstruct by nerve grafts, taking them from the shoulder nerve, most probably from both legs. In some cases, we have to do osteotomy of the clavicle to reach our target distally. We should understand that nerve surgery is not like vessels, which should be watertight. You only have to put the nerve graft without any tension smoothly between the two ends of the nerve so that the natural process of regeneration, sprouting, and nerve fibers cross and regenerate to reach their target at a rate of 1 millimeter after 3 weeks from surgery. Certain points to consider. First of all, there may be injury of the phrenic nerve, stretch of the phrenic nerve, and these patients present by chest infection, and plain X-ray is mandatory to diagnose these cases. Also, you should put in mind some differential diagnoses which are given the same picture. If the surgeon is not experienced, he will be confused, like in cases of CP or arthrogryposis. EMG nerve conduction is important for medical legal aspects. Sometimes, and you should consider that it sometimes happens on both sides, this brachial plexus, in very severe injuries and difficult labors. Some surgeons prefer to do CT myelo or MR myelo to detect the type of injury if it's an avulsion or a rupture. In this work, we have reviewed our cases coming as follow-up in 5 years by the physiotherapy team. There were 66 patients. The follow-up varied from 1.5 years to 6 years, and the physiotherapy team evaluated the shoulder and elbow function and had a scoring system. They used the mallet scale for shoulder function, hand to mouth, hand to head, hand to back, and also the Gilbert-Raymond score for elbow flexion extension. And they measured the muscle strength according to the British Council, the power of the muscle against gravity or against resistance. From these results, the muscles improved with statistical significance in all cases, and we reached excellent good results in almost 82% for biceps and for the supraspinatus, the deltoid, and the triceps. And the mallet and Raymond score improved in all these patients. I will show some presentation of cases to see the effect of microsurgery. These patients should be early diagnosed, and as long as there is no biceps and no flexion of the elbow, this is an indication of surgery. As you see here, we do exploration, nerve grafting, follow-up of the patient. This patient has very nice teeth scar, and there is beginning of the elbow and shoulder movements. At a later follow-up, as you see here, there is much improvement of the elbow flexion and the elbow overhead elevation. This is our aim, to save these patients from bad results by early exploration and reconstruction of the nerves. This is another case in which you had extended C5, 6, 7 injuries. We explore the brachial plexus, as I said, through this V-shaped incision, and then we go after the phrenic nerve proximally until we reach C5, 6 and localize the lesion if it's an avulsion or if it's a rupture. Distally, we dissect until we reach the anterior division of the upper trunk, anterior and posterior division, and the suprascapular nerve. This needs experience to detect the level at which the nerve is injured, and we resect the neuroma and prepare the nerve for later reconstruction by nerve grafts. We take our nerve grafts from the shoulder nerve from both sides, under microsurgical techniques, we reconstruct the brachial plexus and we use the fibrin glue as to stabilize the nerve, so that in rehabilitation, we don't have to put this type of cast, but to put a bandage all around the chest of the patient. And this is for 6 weeks with special hygiene for the wound. And as said Dr. Ayman, the patient education is very important so that there is no contractures. The hand appears outside the bandage and needs a little bit of manipulations. During feeding the patient, there should not be any soiling of the wound. As you see here, this is the early result with good scar. And I always repeat, a good scar means good hygiene. And this is the early result of the patient. As you see here, he has improved elbow and shoulder function. And then in a later stage, there's improvement of the triceps and the shoulder elevation. And at a later stage, the scar does not appear and the patient has much better results, as you see over here. He has good deltoid, biceps, and the triceps. This is our target. We want to reach these results. To reach these results, there should be early interference at 3 to 6 months. We should not delay our exploration as long as we are sticking to the indications of reconstruction. This is another interesting case in which we had also, together with the brachial plexus injuries, we had a dislocation of the shoulder. So the patient presented with this shoulder dislocation, neglected shoulder dislocation, because he was subjected to physiotherapy. And as said Dr. Ayman, physiotherapy in the early period of the life of the child is home exercises mainly, without any rough manipulations like in the physiotherapy. They were so concerned with in this age, and they use stretching and external rotation so that they can correct the contraction, which does not happen in this age. This ended by a dislocation of the shoulder. So I had a brachial plexus injury and also a dislocation of the shoulder. We had to explore also, as you see the incision, until we reach the shoulder, explore the brachial plexus, also infraclavicular, to reduce the shoulder. This was a tough surgery, long duration, and we could have it could have been simpler if we had obeyed the rules of physiotherapy and did not do any rough manipulations. So this is the early results of the patient. Then there's improvement of the elbow flexion, the shoulder, but still we did not achieve the good function which we are waiting for. But in a later stage, the elbow improved, the triceps improved, but still the patient does not have any overhead elevation. We cannot stop at this. We want him to reach overhead elevation, which is important so that the hand can reach far objects. Our aim at the end is to reach the best results in this early age of these patients. So we had to do a muscle transfer. Through a transaxillary approach, we reach the latissimus turci and we use it and we put it at the insertion of the rotator cuff. The patient is later put in a cast and external rotation for 6 weeks, then rehabilitation. And this is our results of a good overhead elevation, and the patient returned to some sports like swimming. So our aim at the end is to treat these patients early as possible so that we do not end with a handicapped child, and at this old age, you cannot treat these patients by the technique of microsurgery, which I think in proper indication saves the life of these patients. So our results depend upon the age, should interfere early as possible, the pathology of the lesion, if it's an avulsion or a rupture, the surgeon's experience and the knowledge of the topography, his microsurgery techniques and his perfection in dealing with the nerves. He should have a very good anesthesia team and a physiotherapy team with a fixed protocol for physiotherapy. And you always should remember that second procedures can be important to reach the maximum result. Thank you very much.
Thank you, Professor Yasser, for this very nice presentation. Now, Professor Antoine Rocher will talk about correction of bone deformities in Erbs palsy. Dr. Antoine? Dr. Antoine, please unmute yourself.
Hi, good evening. I'm Dr. Antoine Rocher from Albert Luthuli Hospital. Sorry. There we go, sorry. So glenohumeral deformities, it's quite complex. I thought before that it's due Dr. to just Antoine, muscle imbalance.
Excuse me, please, can you share your screen?
Okay. Sorry. Is that better?
Excellent, excellent.
Sorry. So the deformity in glenohumeral joints is a bit more complex than just the internal rotation. There's a abduction deformity, which can't really be explained just by muscle imbalance. And just in this video, I'll show you what happens is you get an abduction deformity and the acromion starts pushing onto the humeral greater tuberosity, and it pushes the humeral head posterior to the glenoid. So as I said, there's due to the muscle forces, you get this internal rotation first, then you get the abduction deformity, which is not what you'd expect, as most of the abductors are weak. And this basically translates into a shear deformity. And in these pictures here, you can see from this article from Dr. Nath, on the left side, as it progresses, you can see more and more of the superior medial part of the scapula protruding above the level of the clavicle. If you look at the shear grade 3 group there, you'll see that the acromion is elongated. You can't see the coronoid, but the coronoid can also be elongated with these patients. And the superior medial part of the scapula protrudes almost 50% above the clavicle, and it pushes this humeral head out. And if you compare it to the left side, to the right side, you'll see that there's an increased angle. And this doesn't make sense just with muscle contractures. So a lot of the literature talk about this muscle imbalance or muscle fibrosis in the older children, but this article that I found really explains it well, and they make a good argument that it's a longitudinal muscle growth problem. So because there's a peripheral nerve injury, the muscles just don't grow as they should. So they still function as normal, but they can function if you get axons to them in time, but they're much shorter. There's less mesomeres in between. And part of this, of the argument is explained by the FFD that you see in the elbow. So although the elbow flexors are weaker than the triceps, they still get a FFD, and the suprascapular, the supraspinatus muscle causes an abduction deformity as well as the deltoid. And also the superior part of the subscap muscle, which is supplied by C5 and 6, contributes more to this contracture than the lower part that's got a C7 innervation. So this is one of my patients. She's got an affected right arm, and I want to draw your attention just to the right elbow that's slightly flexed. The arm is slightly pronated, postured. And if you look above the clavicle on the right, there's a little hump called the Patty sign. And you can also see the sloping. So I'm going to ask her to move her arm And then you'll see the trumpeting that she performs to try and get her hand to her mouth. And you can also see the scapula moving at the clavicle. So just look at the scapula there. So this is the functional deformity that this kid's got. And you see on the right side there, the protruding scapula from the back. So we call this the putty sign. So another functional assessment that we use, you'll probably hear about tonight a few times, is the mallet score. So it's just a scoring system. We can't do a dash score on these kids. So most of the authors use a before and after mallet score for function. Then you can also do imaging on these kids. And here you can see that same kid of mine who's got this putty sign, and you can appreciate the elongated acromion there. That's mostly pull from the deltoid. So because the deltoid don't grow, it pulls on the acromion and you get this lengthened acromion. And just, you can also appreciate that there's an abduction deformity, which doesn't make a lot of sense if you think that most of the adductors is actually stronger than the abductors. So then you can do CTs or MRIs depending on the age of the child, and you can do some measurements on that. So Dr. Prof. Waters et al., they described this portion of the humeral head anterior to the scapular line. So if you take a line like on the picture there, on the scapula, and this view is usually just below the base of the acromion. So it's a transverse cut just below the base of the acromion, of the coracoid. You can measure the portion, and as the humeral head subluxes posteriorly, you'll get less and less percentage of it. And so if you get 35 to 0%, it will be a subluxed shoulder, and then less than 0% would be a dislocated shoulder. Then Friedman described this angle. So the Friedman angle is 90 degrees minus the alpha angle. So for instance, if the alpha angle is 110, it'll be minus 20, which is a retroverted shoulder. And then Waters made a classification. So if you look at this classification, the type 1 and type 2 doesn't usually need osteotomies or any correction. Maybe some tendon transfers will assist them with remodeling, but the type 3s to type 5s are the typical ones that's indicated for surgery. And here you can see on the picture there, there's an abnormal shoulder on the right. So there's a Friedman angle of minus 20 there. The alpha is 110, so 90 minus 110 would be minus 20. And then you can also see a significant portion is behind the line there of the humeral head. Here's a significantly dislocated right shoulder with extreme retroversion, and you can also appreciate the flattening of the humeral head on this picture here. So with the corrections, I'll describe two of the ones that I found. So it's not as well established as the nerve surgery or the tendon transfer surgery. Dotwell and co-workers, they described a procedure just to improve the retroversion. So they did a combination of soft tissue procedures with a big L incision in the back. So you can see on the picture there that they exposed most of the shoulder from the back there. And then they will release the teres major, the latissimus dorsi, and that will eventually be transferred just anterior to the infraspinatus. They'll release the infraspinatus and the posterior capsule, and they'll insert a bone block that they get either from the posterior part of the acromion or from the medial part of the scapula. And then they will close the infraspinatus and capsule with no tension, so they won't try and reduce the humeral head. Otherwise, you lose too much internal rotation. And then they will decide if they've got a adduction contracture, they'll release some of the subscap of the supraspinatus muscle off the scapula, or if there's an adduction contracture, they will release the long head of the triceps with that. They will also release this subscap muscle from the back by going just under the infraspinatus and sliding a Bristol or a periostal elevator up the scapula and releasing the subscap directly from the scapula. So they took patients with Waters type 3 to 5. They had quite a wide range of ages that they treated. And the outcomes after about 2 years were quite good on the mallet score. So the functional outcomes was quite good, but the patients did lose some internal rotation in both active and passive movement. And the percentage of humeral head above the scapular line improved quite a lot, as well as the retroversion. So the X-ray pictures looked much better. Another osteotomy, I'm not sure who described this first, but Dr. Nath from Texas probably wrote most about this. So there's a virtual triangle called a acromioclavicular triangle. So you can see in this shear deformity here on this patient, that triangle is pronated and pointing downwards. So the idea of this osteotomy is to resect the lateral third of the clavicle and also release the acromion from the base of the scapula. And that allows the rest of the scapula to move upwards and to rotate back to a more normal position. So this is an article from Egypt, from Zagazig University, I think. And you can see the post-op and the pre-op and post-op, and how good the shear deformity corrected from such a osteotomy. So Dr. Nath basically described a quite soft tissue procedure where they also transfer the teres major and the latissimus dorsi, and they do a neurolysis of the axillary nerve. And then together with that, they do this acromion osteotomy, clavicle osteotomy, and this scapular superior osteotomy. So that little supromedial part that causes the patty sign. So that's almost more of a cosmetic surgery to just take that tip off. And then you also have some bone graft that you can put into the clavicle osteotomy, and so they morselize that into the defect in the acromion and the clavicle to help with repair. They also said it's worthwhile to just tag the ends of the clavicle loosely together so that you don't get non-unions. So he had an article, so his first 3-year follow-up showed significant improvement in the mallet function. And he followed 17 of the patients up 10 years later and showed that most of them maintained that improved mallet score. There were some of them that had actually improved more than the 3-year follow-up. And those were patients that they did a biceps tendon lengthening as well. And the main reason for that is it helps with that pronated posturing of the arm. Dr. Nath also did a meta-analysis, and he compared basically his triangular tilt surgery with a derotation osteotomies, and showed that the humeral osteotomies, although they got a slightly better mallet score, the triangular tilt surgery showed a bit better improvement. It's a meta-analysis with a wide range of ages and indications and type of surgery. But I think this triangular tilt surgery does make a lot of sense if you understand the deformity that these kids get. Thank you.
Thank you, Professor Antoine, for this nice presentation. A lot of osteotomies to discuss in the end. Now, Professor Ajmal Ikram will talk about muscle transfer and reconstruction in Erbs palsy. Dr. Ajmal?
Yes, thank you.
Welcome. You're welcome. You can share your screen and begin, please.
Okay. Can you see the screen?
Yes, it's clear.
Okay, thank you.
You're welcome.
Okay, I'm going to talk about muscle transfer and reconstruction in Erbs palsy. In the shoulder, the disease progress, we have talked about earlier about this. About 35% of infants and children with brachial plexus palsy experience some degree of shoulder weakness, contracture or joint deformity, which happens due to the soft tissue contractures, resulting relatively unaffected internal rotators and adductors versus weak external rotator muscles. Muscle imbalance in the shoulder lead to a deformity in the glenohumeral joint, which leads to a further limitation of range of movement and the strength of the movement and the function of the patient. This all hypothesis was confirmed with recently analysis of the muscle volume in the patients with the brachial plexus. So about 60 to 80% of children who do not recover full motor function have some degree of glenohumeral deformity. Moderate glenohumeral deformity develops within first 2 years of life, and in 60 to 70% of children with internal rotation contractures. Deformity progresses with the age, and it is correlated with the shoulder rotation contracture. Long-term effects of glenohumeral dysplasia remains unknown in these kids, and some of the authors have postulated that this deformity may predispose the children to the pain and arthritis in future. So the children with established internal rotation contractures and glenohumeral incongruity are unlikely to regain full optimal function until some soft tissue procedures are not done, so that there can be remodeling. We do the assessment. We have talked about this one, modified Mallet score. We have done imaging in this patient, especially MRI scanner, which shows secondary changes in a glenohumeral joint, and possible one can do intervention to prevent the deformities. Ultrasounds can be done to see the muscle innervations which have recovered or not. CT myelography, it was done before, but not many authors now recommend it because of its invasive nature. Standard X-rays of the chest to diagnose if there is any phrenic nerve injury or is helpful. EMG is only indicated in a patient where we have prognostic value is not greater. And we will only do in whether we are planning to do neurotization in a patient where we have already done some nerve work. So how do we manage this patient? What are our indications? In infantiles, which had a dislocation, or there is a persistent internal rotation contracture, which is refractory to the physiotherapy, and they have limited active abduction and external rotation of the shoulder, which have been plateaued, and there is of the neural recovery, there is no further neural recovery. Principle in these patients are to release a contracture, deal with the muscle rebalance, and get a joint reduction to get a better function in the shoulder. Principles in the muscle transfer remain the same as done by Brands, that the transfer and recipient muscle should have similar discussion and tension. Transfer muscle should have at least more than 4 great power. Transfer and recipient tendons should have similar line of pull, and transfer muscle should design to replace one function. For example, if there is an external rotation, so one muscle should be used for that. What are the surgical options? Fairbairn and Severs described initially the musculotendinous procedure in early 20th century, which involved Z lengthening of subscapularis and pec major. Later on, Lee Episcopo described transfer of teres major and latissimus dorsi to the rotator cuff, in addition to the lengthening of the internal rotators. Many of authors, they advocate not opening the joint to prevent anterior or inferior dislocation or stiffness of the shoulder. Chen at all, they suggested improvement in both shoulder abduction and external rotation could be achieved by transfer of trapezius to the humerus and transfer of lead dorsi and teres major to the rotator cuff. Hofer and Phipps, they did anterior release of pec major and transfer the latissimus dorsi and teres major to the posterior part of the cuff with extra-articular technique and showed good function earlier. But however, later on series of the same technique, they did not get a persistent results because of a considerable amount of glenohumeral dysplasia. And they advocated a extra-articular procedure alone are insufficient in joint reduction and remodeling. So what are the new concepts in the shoulder tendon transfers? I think one of the most important concepts to surface from literature in recent years is the effect of soft tissue procedure on osseous formation of the shoulder. The data suggests that without congruent intra-articular procedure, improvement in the shoulder motion can be gained, but little correction in underlying osseous deformity occurs. So if we look at the series by Hu and Tarod, they reported an open reduction of the glenohumeral accompanied by tendon lengthening and transfer could reduce abnormal glenoid retroversion in young patients with brachial plexus buds palsy. Importantly, intervention also lead to a joint remodeling and improvement in glenoid retroversion of 30% of the patients. If we look at the recent literature and the studies, they have increasingly looked at both functional outcome and potential for remodeling of glenohumeral joint after soft tissue procedure and joint reduction procedures. Waters et al. Showed good improvements of glenohumeral dysplasia in 83% of patients with a combined intra-articular and extra-articular procedures. Glenoid versions were also improved in their studies, and humeral head anterior to the midline glenoid improved also in their studies. Scott Cousin and Pearl, they did an arthroscopic approach where they have demonstrated a release of scapulohumerus tendon and anterior release of the glenohumeral joint in isolation or in combined with the lead dorsi and teres major tendon transfer have shown improved external rotation and the concentric humeral head in the glenoid. Similar type of results were also again reported by Pearl. Another tendon transfer, which is described recently by Al-Hassan and Shin, which is the lower part of the trapezius transfer, which is gaining more popularity because of his better functional outcome. And this technique can be used in a pediatric patient with the brachial plexus, even where the previous tendon transfer has failed. It has advantages that line of pull is directly in alignment with the infraspinatus. What are the contraindications in these patients for this transfer is incongruent humeral joint with flat humeral head, which can be diagnosed in a CT scan. If there is a congenital absence of lower trapezius muscle or there is a lower trapezius pulses after the brachial plexus injury or previous surgery. Lower part of the trapezius is transferred with the fascia, then there is no need to have a tendon interposition there, and in 30-degree abduction and external rotation, and the patients are kept in a spica for about 6 weeks, and these authors have shown very good results with that. There are many studies in literature where the teres major transfer to restore the external rotation of the buds palsy has been done, and they have showed very good outcomes. There has been also studies on a double versus single tendon transfer where lead dorsi or single transfer was done and the lead dorsi and teres major transfer was done. And they also have shown sufficient good results in one of the meta-analysis done by Scott Cousin. If you do a tendon transfer around the shoulder with the CT scan studies, this had also a study done in Egypt, and they showed a good improvement of a patient glenoid retroversion if the tendon transfer done between the age of 2 and 4 years. And there was a significant improvement. After the age of 4 years, improvement in motion was not significant and the secondary bone changes were not prevented. So they recommend doing this transfer at early stages. In summary, I think the tendon transfer procedure should be done and they should be individualized depending upon the age and intervention, and type of procedure depends upon the problem and severity. Ultimately, the limitation in function and severity of glenohumeral deformity influence the type of and secondary procedure which can be done. These options include the extra-articular musculotendinous lengthening, tendon transfer with or without intra-articular release performed either open or arthroscopic procedures. If there is a more severe osseous deformity, I think alternative options such as derotation humeral osteotomy or glenoid osteotomy should be considered in these cases. Thank you.
Thank you, Professor Ajmal, for this nice presentation. And I think you passed and you said all the options that we can do about muscle transfer. Now, Professor Muhammad Qutb will talk about the role of arthroscopy in treatment of Erbs palsy. Professor Qutb. Dr. Muhammad.
Yes, Assalamu alaikum.
Alaykum assalam wa rahmatullahi wa barakatuh.
It's my honor to share you this evening webinar about Erbs palsy, and my talk will be about the role of arthroscopy in such cases. Can you see my screen now?
Yes, Professor Muhammad, you can begin, please.
Okay. The problem is in the involvement of C5-6 plus or minus C7 roots mostly results in progressive problem in glenohumeral joint, as been shown in the previous talks of my previous colleagues. And regardless of the treatment at infancy, contractures of internal rotation together with weakening of external rotators that might lead to progressive bony deformities. As we see from the CT on the right side, which with AA, the marked bony deformities in the glenoid and the humeral head shape in the form of retroversion, flattening of the humeral head, and hooking and lengthening of the acromion, as been shown in the previous classification of waters, and eventually might lead to posterior subluxation or even dislocation of the shoulder. The first mention of the role of arthroscopy in treating shoulder contraction in Erbs palsy was reported in 2003, and they released the subscapularis and the capsule, and in some cases they needed additional tendon transfer. Following this report, a lot of reports mentioning different procedures. However, there is no consensus about the age limit, what are the structures you have to do, and what are the contraindication to not to do arthroscopy in such cases, and what cases does need additional tendon transfer. This is a recent study also, 2019, about the arthroscopic release. They did 9 arthroscopic subscapularis release, and in some of them, they added open release of pec major and additional latissimus dorsi transfer. So the technique we adopted actually work a lot in infancy or children. However, some of them were adults, but I will leave the adult group for Professor Bassem. He will talk about the role of arthroscopy in the adult group. And we do multi-slice CT for post shoulders to exclude the cases which might not need arthroscopic intervention. So we are working on the group between type 2 to type 5 Waters classification. Clinical examinations, shoulder abduction should be above 45 degrees, meaning there is a deltoid working, internal rotation deformity contracture, meaning limited external rotation, and in some cases, if there is co-contraction between biceps and deltoid, which is called the trumpet sign, has been shown in a previous talk. And this is examples of measuring the alpha angle, which was mentioned before in the previous talk. And this is a clinical examination of a preoperative photo clinically. So our technique will be in the lateral position, and we use 2.7 30 degrees scope, like where I use in the wrist and elbow scope. We do subscapularis and coracohumeral ligament release combined with the superior glenohumeral ligament. In some cases, we do acromioplasty through a subacromial decompression, and this might be added in the adult group, and plus or minus also coracoidoplasty, because some hooking coracoid will impinge on the anterior part of the humeral head that will prevent the external rotation. These are some intraoperative photos showing the contracture of the subscapularis and superior glenohumeral ligament and after release. And this is intraoperative photo showing post-operative clinical video showing the passive range of motion of external rotation, either in adduction and abduction after finishing the procedure of the release of subscapularis and the coracohumeral ligament. And this is the early post-operative follow-up showing improvement in shoulder abduction and external rotation and without loss of internal rotation, which is the mandatory function for this stage. This is another example also of a late follow-up. This is 2 years post-arthroscopic release of the shoulder without tendon transfer. There are some contraindications in our point of view. Total palsy, neglected late presented cases with no previous nerve reconstruction, marked glenoid dysplasia, posterior sub or dislocation, and past history of septic epiphysitis proximal humerus, which might be associated with brachial plexus palsy. And this is an example of posterior dislocation. On the left side, you can see in the CT, the humeral head is completely dislocated with marked hypoplasia and retroversion of the glenoid surface. And this is, from our point of view, the contraindication to do arthroscopy. And to show it clinically, these are two examples. Examination under general anesthesia preoperatively and showing absolute loss of external rotation. Even you cannot reach the neutral position of rotation, either in adduction or abduction, and the CT we have seen before with posterior dislocation. This is, from our point of view, is a contraindication to do arthroscopic release. And this is another example that will benefit from arthroscopic release because you can do some little external rotation, either in adduction or abduction under general anesthesia. And this will benefit from the anterior shoulder release arthroscope. This is an example of an open reduction for the posterior dislocated shoulder. This is after release of the subscapularis, the superior glenohumeral and coracohumeral ligaments, and even the anterior capsule, because there was a severe contraction that led to this posterior dislocation. And you can see the humeral head reduced centrally into the glenoid after the complete anterior release intraoperative. So the take-home message, the scope provided effective and safe for obstetric brachial plexus for the anterior shoulder release in such a group of patients. Same results as open technique. Subscapularis and coracohumeral are sufficient for satisfactory release, and better to be used for patients who are not planned to do tendon transfer. There is a relative contraindication for posterior subluxation and dislocation. And this is my talk for today. I hope you get benefit from it. Thank you.
Thank you, Professor Muhammad, for this very nice talk and nice case presentations. Now, our last talk is by Professor Bassem Flega about arthroscopic options in patients above 20 years old. Professor Bassem.
Thank you, Professor Rami. I have I will talk about some arthroscopic options in treatment of Erbs palsy in patients above 20 years of age. As said before from my colleagues, that the problem of external rotation and limitation weakness lead to internal rotation contraction and progressive glenohumeral deformity with elevation limitation, and this even in adults if they are not treated early, probably. Now, in all ages, daily physical therapy is the most effective treatment of Erbs palsy. From the literature, some open procedures in adults are used as an arthrodesis of the glenohumeral joint, derotation osteotomy, capsule repositioning was described to manage these cases. Now, what are the arthroscopic options in treatment of Erbs palsy in adults? From our experience, we use three types of management, either only arthroscopic anterior capsular and subscapularis release to improve the range of external rotation, or arthroscopic subscapular release with open latissimus dorsi transfer to improve the range of external rotation and the strength. And the third is for limited goals to do a soft tissue and bony reconstruction in cases who have not used the shoulder, to let them gain some sort of function of the arm. The subscapular release, there are three different types, either to do a longitudinal anterior capsular release or cut, or an oblique subscapularis lengthening, or a sieve capsular release. I usually prefer the oblique subscapularis because contact between the two parts of the subscapula will remain in the middle. This is a patient who had actually a good elevation, but his external rotation was not proper. So we did a subscapularis release. It gives him a sort of better external rotation, but it is less than, of course, the other one, but it helps him in the function of the shoulder. Now, if there is also a weakness with the limitation of external rotation, we do a combined arthroscopic release of the anterior capsular and subscapularis, as well as open posterior capsular shift or inferior capsular shift and latissimus dorsi transfer. This is a 20 years old patient. He had a relative elevation more than 90 degrees active elevation, but his problem was minus external rotation. So we did the procedure of subscapular release and latissimus dorsi transfer, and then we immobilized the shoulder in external rotation for 6 weeks. After surgery, he gained a very good active external rotation, as you see, compared to the preoperative. This patient did very well for 2 years. Then he started neglecting his exercises daily, which led to a worsening of the range of motion. Now, in adult patients who never used the shoulder or the arm for daily living needs, and actually they were living only using one arm, we also tried here to do an anti-arthroscopic management with limited goals of soft tissue and bone reconstruction. Our goals were to let the patient use the arm for eating, writing, and shaking hands, which is a very important function of a person, a daily function. So the two bony procedures is to compress or to enlarge the subacromial space to allow for more elevation, is doing an anterior acromioplasty and a resection of the greater tuberosity protrusion. Because of the deformity, the greater tuberosity will be above the niveau of the head. So we resected to let the greater tuberosity space surface below the head niveau. Then we do a subscapularis release to increase the range of external rotation. And finally, we do a release of the inferior capsule to allow for more elevation. The supraspinatus and the superior capsule are responsible for depressing the head while elevation, and this is usually redundant and enlarged in cases of Erbs palsy. So we manage this after doing the bony procedure, the subscapularis and the capsule release. We do a T-shaped capsular reefing, a capsular and tendon supraspinatus by making a T-shaped cut and overlapping the two flaps on each other and tying them to the greater tuberosity, which after the resection of the protrusion. For this procedure, we use a transosseous fixation of the tendon using the giant needle and the so-called chop needle for pulling the sutures. As you see on the right above picture, the T-shaped incision, and then we place a suture in the bone and pull it through the posterior flap, thus fixing the posterior flap to the greater tuberosity, pulling it anteriorly, and over it we fix the anterior flap by pulling it posteriorly above the posterior flap. And thus we get shortening and reefing, doubling of the capsule and supraspinatus tendon. This to resect the greater tuberosity, as you see here, and with an abrader to be above, below the head, and then with the giant needle we go through the flap of the supraspinatus and then tie them to the bone by pushing the needle and the suture through the tendon and bone, and then tying it as described before. Now, this is a case of 27 years old patient with Erbs palsy. He has an active elevation of 40 degrees and active extension -20. So actually all his life he didn't use the shoulder for any function, and he used also always the other arm. So we did this above mentioned procedures for the limited goals to allow him to shake hand, to write, and to eat. This is the patient 3 months after surgery. So he is able to have a fairly good external rotation from -20 to +20. And also the elevation was 80 to 90 degrees, which allowed him to do the functions said before. This patient had an immobilization in an abduction brace without any exercises. Then after that, we started exercises daily for 30 months, and he continued these exercises for 1 year. And after that, daily 15 minutes exercises. And 3 years after surgery, the targets of improving the range of motion and active function have remained. He every day in the evening take a shower and do a stretching of external rotation and stretching of elevation, as you see in the pictures on the above left, and also strengthening of elevation and external rotation. These exercises kept this situation which we reached all these 3 years. In conclusion, arthroscopic limited goal treatment of Erbs palsy in non-functioning arm in adults is a less invasive technique, has good results are possible. Post-operative daily rehabilitation is essential. The results remain only with continuing exercises. The patient, if he just stop the exercises, he will get worsened. So we have to tell them that. And in final conclusion, arthroscopic reconstruction is an option to consider in non-functioning Erbs arm in adults. Thank you very much for your attention.
Thank you, Professor Bassem, for this very nice presentation. Difficult cases with very difficult decisions to take. And now we will begin our discussion. Please, Mohammed, open the videos. You are blocking the video. Now we will start our discussion. We have a lot of questions. We'll begin by Dr. Ayman. Dr. Ayman, please tell us, does investigations, EMG or MRI or CT myelogram, are they necessary for your decision? And if they change your procedures, what to do?
Yes, I think that in the early days, when you first meet the baby with a brachial plexus, it's all based on a clinical examination. There is no need to do a nerve conduction study or an EMG, because it will only diagnose that you have a brachial plexus palsy, and this is evident without need to do an investigation. Maybe if you need further detail, you can start doing this after 2 months of post-natal, because then you will have maybe a benefit of telling you what is the regenerating, what's to help to localize the site of injury. That will make such an investigation of a value. But to do it early in neonate with 7 days or 10 days after birth, I think it has no value at all. Sometimes when you are planning for a surgery, you should, even for medical legal purposes, do such an investigation. If you meet a child at 3 months old and he does not recover his biceps yet, then you should do the nerve conduction study to document the injury. Sure, at 6 months, it's also helpful to document what is going on. For the MRI myelogram, I think it's can help you if you are intending to do a surgery that will involve critical decisions. And you need to have an overview what of the 5 fruits are still preserved to give the parents an idea about the outcome of the procedure. Then you need to document which route you will find, so to avoid any unexpected surprises during surgery. But to stick to my talk about conservative treatment, I think the nerve conduction side does not play any role. The investigations are directed towards the part when you are pushing your child towards the operation side. In the conservative management, it always depends on your sense and what's expected to do. If you start exercises on a daily basis, it's a home exercise. You teach the parents, and you follow up your clinical outcome by what muscle is recovering, and how the elbow is recovering, how the shoulder is recovering, and you build your decision and your what you need to add later on. For the CT myelogram, I don't think it's a very good idea. For nowadays, MRI myelography had replaced it, but it still needs special centers to do it.
You mentioned electrical stimulation for the child.
Yes.
As in physiotherapy.
As a complementary method. I do not recommend electric stimulation in young neonates. In my patient, I do not prescribe the electric stimulation per se. The aim of such an exercise is to do passive stretching of whole joints to try to counteract for the deformities that will set on, and also the sensory stimulation is very important. You try to make the child grow with using 2 arms, not 1. This will help him if he continue to in such a conservative treatment after the first year.
Yes, but you see, all children are doing electrical stimulation.
Yes,
and you find children 3 and 4 years old coming to you and doing electrical stimulation from day 1 till now.
And sometimes they're doing only electrical stimulation, the whole session, the one hour session of an electric stimulation, electrocution of the child.
Yes. When do you tell the patient to stop electrical stimulation? At what age?
Yeah, I'm always trying to push it away from electrical stimulation. I don't think that electrical stimulation have any value except to prolong the nature of the muscle to be responsive if you are planning for surgery. You should use such an stimulation if you are planning for a surgery, and you need to do it at 7 months or 8 months. So you have to have a baby with a muscle that have still the ability to contract. You try to prolong their responsiveness by the electrical stimulation. The process of the recovery, it's a natural process. It occurs by itself without any electrical interference.
If you allow me, Dr. Rami and Dr. Ayman, electric stimulation with a paralysis muscle results in fibrosis of the muscles. You only can begin with a certain protocol after the muscle begins to move and contracts. So as Dr. Ayman said, there is no role for electric stimulation as long as the muscle is paralyzed.
Yes, yeah, sure. It's going here to see it like it's a malpractice. It's the only thing that is given to a child, and it's the least thing actually that it will benefit the child.
I agree totally. Yes.
Okay, thank you. Romy.
I think Rami lost the internet connection.
Dr. Yasser, I wanted to ask you about your practice. I've helped you in a lot of such babies in microsurgical reconstruction of brachial plexus. Do you apply the rule of 3 months and 6 months, or you have a tolerance to use it on elder children, babies? You stick to the rule of 3 months, or try to have it?
I stick to the rule of 3 months, and I find a great difference in the degree of fibrosis between the patients who are 3 months and those which are 6 months. It's like doubling their age. If it is indicated for surgery at 3 months, as the video I showed, or the patient, there's no movements at all of the shoulder and the elbow, then you should be as quick as possible. You will find the pathology much better to identify, and less fibrosis, and you can reach the normal the cuts which you need to reconstruct away from the neuroma if it's proximal and distal. So I always like to operate as early as possible.
Yes, time is muscle, as we said. Yes,
yes. Professor Yasser, about that point, this difference is more apparent when you have a PAM plexus injury. But in upper trunk, there are authors that say that you can operate at 3 months, 6 months, and even 9 months, like Howard Clark. And he said that there is no big difference in upper plexus injury. What do you think about that?
I think it makes the clinical picture and the decision making very puzzling.
Yes, yes.
That's my experience.
Yes.
And as Ayman said during his talk, that sometimes you follow up the patient until they are 6 months, and then you don't have good shoulder function. Then it's a dilemma. Are you going to interfere and do a nerve transfer to reconstruct the shoulder, or are you going to wait later on for muscle transfers? So for my experience, I take my decision as early as possible, as long as I receive the patient early. If I receive the patient early and I'm doing the follow-up by myself, if at 3 months there is no shoulder or elbow, then I operate directly.
Okay. Dr. Yasser, there is a question. Now, you mentioned neurotization or nerve transfer. You mentioned suprascapular to spinal accessory nerve.
The spinal accessory to suprascapular.
Sorry, spinal accessory to suprascapular. Now, you said that you do that in 11% of your cases only.
Yes.
Yes, and
I don't believe that nerve transfer are superior to nerve reconstruction. So I do this only if I'm stuck with a number of nerve grafts. If I only find that I'm going to do my reconstruction on C5 and there's a long gap and I'm short of nerve grafts, then I reconstruct the anterior and posterior division separately from the suprascapular, in which I do a neurotization.
And
but
what do you do?
I always reconstruct through all the targets from the nerve root by nerve grafts, except if I'm short of the nerve grafts and I need extra, so I do a neurotization from the spinal accessory.
Now, and what if C5 or C6 or both are avulsed? What do you do? What's your strategy?
I never found a complete, especially in C5-6, but in global types maybe, but in 5-6, I did not face at all that I did not find anything to do my reconstruction. This is my experience. A lot of surgeons do not agree, but in selected C5-6, I always found, to my experience, I always found a route in which I can do my reconstruction. I always reach the phrenic nerve, and I go as high as possible by the phrenic nerve where it intersects with the C5. I go very deep until I find the root, even if it's 3 millimeters or so. I have my technique that I leave a stump through which I pull so that the nerve can just come outside the foramen, and then I do my anastomosis, bring all the nerve grafts with a fibrin glue all as one piece, and then I push it inside with very fine sutures and depend on the fibrin glue.
Thank you, Professor Yasser. Thank you. Now, Professor Antoine, please, you told us that you do the osteotomy when there is bony deformities. Now, if you have no bony deformities, would you consider humeral osteotomy in cases which need external rotation?
No, so the only indication for surgery would be the type 3 to 5 waters. My experience is mostly with tendon transfers and nerve. I do a lot of baby nerve surgery and adult nerve surgery, but I've got very little experience with these osteotomies myself. And if you look through the literature, I don't think there's a lot of people who actually do these surgeries. And the research was also very scanty. You know, it's wide ranges of patients under 1 year to 17 years of age. And then it'll be like a group of 15 patients. So I don't think it's well established yet. And I don't think there's a lot of people who's got experience with these osteotomies. I'm not sure about you. I know there is a surgeon who's published on it in Ethiopia.
This is a question for all the panel. Some cases when we do, we see the patient with abduction internal rotation osteotomy, like the ones Professor Antoine showed us. Now, the triangular tilt surgery, I didn't know about it, but as you said, it led to some external rotation deformity or loss of internal rotation, which I think it's catastrophic for a patient. He will not be able to close his trousers. So simple external rotation osteotomy with adduction osteotomy to the humerus. Does anyone have experience in this operation? External rotation adduction osteotomy.
At an old age, you mean at an old age?
I mean, 4 to 10 years.
As a salvage, I mean, that you
Yes.
don't have other options, and you still have like a severe internal rotation deformity, and you want it just to correct the position of the hand without aiming for a high functional outcome. That's what you mean, right?
Yes, yes. But
the only problem is that these patients, as Dr. Antoine said, they were not followed up in the literature for years. So if you do an internal rotation, if he has an internal rotation, then you correct it by an external rotation osteotomy. Then by time it internal rotates again, and then you have more posterior subluxation. And I think these patients, and maybe Dr. Bassem sees a lot of them at old age, it will be like a problem as regards pain and severe contractures. For me, I don't do osteotomies except in very salvage cases. But I remember that in few cases after doing muscle transfer, and the patients were okay until they are 13 years old. Then I noticed that there is like a rotation of the whole shoulder, including the deltoid. Everything was just rotated anteriorly, and was very astonishing for me. Then in this case, I had to do an osteotomy to rotate the insertion of the deltoid to be more posteriorly. So this was like an external an osteotomy to correct the pull of the deltoid. This is my experience, and I wish if anyone of my colleagues can give me his experience.
Professor Ajmal, there is something that you would like to say? Yeah.
I think I'm a good fan of external rotation osteotomy. In a kid's any adolescent age. So if a kid doesn't have, there is a glenohumeral abnormality, and they don't have, and they have an internal rotation contracture. So, and I can't do the tendon transfer for them because they're not going to rotate because of the deformity of glenohumeral joint. I like to do a static procedure for them. I call it a static procedure, where my dynamic procedures can't be done. Even if I can't do a soft tissue release, because the release is not going to be enough, there is a posterior subluxation of the shoulder, the humeral head is more flatter, and the patient has a lot of trumpeting. And then I do a static procedure, which I called, and touch wood, I have quite good results with the patients. So that is, I prefer doing it. It gives me a very good results immediately.
Professor Ajmal, I have a question for you, please.
Yeah.
Now, what's your indications for anterior release? When you do a muscle transfer, you may add an anterior release or subscapularis release or not. What's the line of demarcation? I will not do anterior release, or I will do in that case or that case.
Yeah, if there is no passive external rotation, so the typically you will do an arm by the belly, and you can't passively external rotate. So this is my indication, at least to do an anterior release.
Yes, yes. To which degree? To which degree you accept without release?
Passively 30 degrees.
30 degrees?
Yes, arm by the side. Yeah.
Okay. And when you do the release, what's technique? What technique do you like to do?
I don't have an experience here. I'm a hand surgeon, so I don't do the arthroscopic releases. So I normally do the open release.
Yes, from anterior or subscapularis sliding from posterior?
No, anterior release.
Anterior release.
Yes, anterior. I like to do the anterior release.
No.
Yeah.
When you do that, you mentioned the trapezius transfer.
Yes.
Yes, and when you take the lower trapezius, it is said that you may impinge the long thoracic nerve with the medial border of the scapula.
Mm-hmm.
Do you see that?
I have not seen it. I must admit, I only have done a couple of them, so I have not seen that. So I think one need to take precautions and release it better, making the window a little bit better over there. So maybe next time when I do it, have a look at it.
So you don't search for it. You don't see it.
No, I have not particularly looked for it. No.
Okay. Okay.
Yeah.
Now, thank you, Professor Ajmal. Now, Professor Qutb, there is a question for you. Now, when do you think of doing tendon transfer with your anterior shoulder release?
I'd like
to share my experience tendon transfer with the anterior shoulder release, and what case you prefer to do the release and wait for the external rotation to recover by itself.
I want to share our experience regarding the previous question about the osteotomy even, that will explain our point of view for such a problem. We started using teres major transfer to infraspinatus, and we used to transfer it to as much as we can to the bony attachment of infraspinatus. But we observed that those patients will probably have a limited internal rotation, and they presented to us with abduction external rotation deformity even. So this is the only indication for such cases to do internal rotation deformity osteotomy. So we do humeral internal rotation deformity to make our child able to take care of himself, to raise trousers, to unbutton his shirts, and so on. So this is a place for the osteotomy, internal rotation deformity, internal rotation osteotomy rather than external rotation osteotomy. Regarding the tendon transfer, we shifted from using the teres major to using the lower trapezius, as this have been explained biomechanical point of view from the muscle fiber direction of the lower trapezius, which is the same line of pull like the infraspinatus, and it's not at an angle like the teres major and latissimus dorsi. And since we started this procedure, we did not face the problem of external rotation deformity, and also we suture it to the tendon of the infraspinatus away from the bony attachment, so we are not facing this problem anymore. Regarding the second question, how to judge to do arthroscopic anterior release only, or you add the tendon transfer. Of course, the younger the children and the less bony deformity in the CT, we don't use tendon transfer. So in young children, and the patient pre-operatively have abduction and external rotation limited. So we have active external rotation, maybe 5 to 10 degrees. And this prevented from being complete by the contracture of the anterior structures. So only releasing the anterior structures will give him, or will allow him to do the full range of motion of external rotation. And these are the only children that need only anterior shoulder release. Otherwise, if they have no external rotation, no active external rotation at all, so those patients we advise for tendon transfer. And as our paper Professor Ajmal showed, that's the best time to do the tendon transfer and soft tissue procedure is the period between 2 and 4 years of age. This is to reverse the bony changes and stop further bony deformities in the future.
Now, Professor Mustafa, Professor Muhammad, there is sometimes you can see patients 6 months old with severe internal rotation contraction. In these cases, would you like to enter early and do the release?
No, I think this age group will get benefit from stretching exercises in the physiotherapy.
Sometimes it's very persistent and it's painful and it's not released by physiotherapy.
At that time, you can try also the Botox injection and manipulation under general anesthesia. I don't prefer arthroscopic intervention before the age of 2 years because the smallest scopes and instruments we have now is just good for the age of 2 years and older. So I do not recommend the surgery before that age. And I think the Botox injection and manipulation under general anesthesia will give good results in this age group.
Thank you, Professor Muhammad. Thank you. Now, Professor Basim, your age group is very interesting. Your age group is very interesting. Now, in this age group, we usually find bony deformities. And the shoulder is accustomed to function with these bony deformities. When you correct these bony deformities, shoulder function may not be the same. You cannot guarantee that it will improve in every aspect. Sometimes it improves in one aspect and decline in another aspect, like elevation. Sometimes in these cases with severe internal rotation contracture, have a 180 degrees elevation. And when you correct the bony deformities to achieve external rotation, sometimes they lose some elevation. How can you evaluate these things before the operation to see what are you going to do and what are you not going to do?
Actually, I don't correct the bony deformity. I just do a decompression. I enlarge the subacromial space by resecting the greater tuberosity to make it under the niveau of the head and do an acromioplasty. So this will give a more space for the elevation. How I decided before, it depends on the examination of the patient. Like I showed in the first video, the patient had a good elevation, but only his problem was the external rotation, which was not very good. He was not satisfied with it. So we did only a release of the subscapularis, and this gave him increase in the external rotation. This is actually easy if you have a good elevation, if the elevation is normal. In some cases where the elevation is good and also the external rotation. So in this case, I'll try to improve the elevation by 2 means. Enlarging the subacromial space to give more place for elevation, and very important is all beside releasing the subscapularis is releasing the inferior capsule. By releasing the inferior capsule, I will get more motion of the head in the elevation. This, of course, will not bring it to the normal, but it will increase it for to have it at least above 90 degrees, which is very good for patients who has it below that. So it depends on the examination of the patient, what he can do, what he cannot do. So I'll try to target the things he cannot do. And as I showed also in cases who is not completely useless shoulder, so I do all these means with limited goals, of course.
Okay, thank you, Professor Bassem. Now, I think all the questions were answered, and I hope that any one of the panelists have a final remark about our discussion, please. Professor Yasser? Professor Yasser, do you have any final remarks?
Thank you very much. I don't have any comment.
Okay. Professor Antoine?
Thank you very much. I don't have any comment.
Thanks. It was a very good talk. Thanks a lot.
Professor Ayman?
Thanks, Romy. Very good discussion.
Yeah.
Thank you. I think I learned a lot, and it was very nice to be participating with other shoulder surgeons and the cooperation with the hand surgeons. Very nice, very good.
Thank you. Professor Muhammad?
Thank you very much for allowing me to share my experience and to learn from my professor and colleagues. And I would be happy to share in future such events. It will add much to my practice and allow me to help my patients. Thank you.
Thank you, Professor Muhammad. Now, Professor Yasser, would you conclude our meeting, please?
Thank you very much. We want to thank all the participants. We want to thank Dr. Bassem Fliga, the president of the Egyptian Society of Shoulder Surgery. And we hope that we can meet again in another webinar. We're going to announce the coming webinar. It will be in 2 webinars before our final international meeting. We're going to announce in our groups the date of the coming webinar. Thank you very much. And it was my pleasure to participate in this webinar in association with the South African Shoulder Society of Shoulder. Thank you very much.
Thank you.
شكرا دكتور ياسر. كل سنه وانتم طيبين جميعا.
كل سنه وانتم طيبين. كل سنه وانتم طيبين جميعا.
طيبين. كل سنه وانتم طيبين.
Thank you. Bye. تصبح على خير دكتور باسم.
وانت من اهله متشكر قوي على المودريشن الرائع ده.
العفو 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 العفو. مع السلامه. مع السلامه. تصبح على خير. Enjoy your
Yes, thank you. Tomorrow morning.
إن شاء الله. مع السلامة.